What's up, everybody? Welcome to this week's episode of the Well Man's Podcast. My name is Brian Brosey. I'm joined by my friend and co-host, Dr. Keoni Tita. And today we're also joined by a very special guest, Dr. Eli Loch. He currently practices with Coastal Spine and Pain Center in Northeast Florida. He has completed his fellowship in pain medicine and residency in anesthesiology at Shands Hospital at the University of Florida and is board certified in both. He is a graduate of Lake Erie College of Osteopathic Medicine and received his undergraduate degree in finance from Stetson University. Dr. Loch is also a certified health coach and participates in research as clinical investigator with the FDA. Most recently, Dr. Loch has completed additional training in regenerative medicine. He is currently a member of the Regenexx network of physicians specializing in the use of regenerative medicine for orthopedics, which makes him of particular interest to me. So Dr. Loch, thank you so much for coming on and joining us today.
Absolutely, guys. Thanks so much for having me.
Yeah, thank you.
Yeah, so as your background kind of forebodes or leads us to believe, we're definitely going to talk about regenerative medicine today. And I just wanted to start with we got your background, your education a little bit. What does regenerative medicine mean? Is it a catch-all term? What kind of falls under the umbrella of regenerative medicine?
Yeah. So regenerative medicine it's kind of an umbrella term. It's kind of a catch-all term. And really what we're talking about is it's a type of medicine often from an interdisciplinary approach. So different specialties participate. And the goal is to either repair or replace diseased or damaged tissue. So we're kind of trying to avoid more aggressive or invasive types of procedures and trying to repair the tissue that's already there, or trying to basically replace the tissue that's already there that's damaged. So that oftentimes involves the use of certain components from the patient's body, whether it be cells or types of fluid or other things like that. But the end goal again is to repair that tissue so we can try to salvage that tissue.
Okay. And so typically, I know there's a lot of, I guess, kind of different modalities or different umbrellas that fall under the umbrella of regenerative medicine. Is it typically the patient's own cells, or is it what options do we have here?
Sure. Yeah. So that's a great question, and actually jumps ahead a little bit to the FDA part that we might get to in a little bit. But typically the FDA looks more favorably on tissues that's from the patient's own body, which is called autologous. So that's kind of the route that most people in the field take, just because there's a lot of FDA restrictions on using somebody else's cells, and rightly so. Mm-hmm. So most of it is autologous, or using the patient's own cells. Yeah.
Okay.
I had a question as far as it seems like under regenerative medicine, based on what you say, we're basically trying to replace worn out parts or broken parts, right? So it seems like it spans the gamut of like anything from like stem cells creating new hearts, creating new organs, right? That would fall under this also?
Yeah, absolutely. Yeah. So it can have a lot of different applications. So yeah, just like you said, it can follow anything from cardiac and heart issues to, vision and those types of things. The area that I specialize in is more the orthopedic route. And that's a route that's been studied pretty extensively, but it can span, any of these types of things. And obviously it's a very, very new field. And there's a lot of trials that are ongoing. I think last I looked, just in in registered clinical trials, there was around 7,000 or more, trials that are currently involving some type of regenerative medicine, whether it's stem cell or something like that. So it can span a wide range of body areas, of systems, and a lot of it is brand new. Like, obviously the cardiac's gotten a lot of attention, vision's gotten a fair amount of attention. And so and each of those body systems are in various stages. So, musculoskeletal and orthopedics is been around for probably, longer than a lot of the others, whereas cardiac, vision, liver, those types of things are definitely more newer, and there's not as much studies or human data, at least on those aspects.
Just for the interest of our listeners, I mean, basically what I hear is we're replacing broken parts. I mean, this could lead to significant life extension, right? For a lot of people. I mean,
I think and we got to be careful because again, it's really, really new. And, I'm always very clear with people when I see them as patients that, we're not to the point yet where I can regrow you a new knee or something
Right.
or regrow, a new disc in your back. I mean, it's not there at this point. Will it get there in the future? I think at some point it probably will. But, really what we're looking for is trying to, again, salvage what we can out of that tissue, try to, yes, not only life extension, but also, and so not only lifespan, but health span. So making those years that are available, more quality years. So, for example, I see a lot of, pretty severe osteoarthritis or, disc problems in the back. And, like I said, we're not going to regrow a knee, we're not going to regrow a disc, but, a lot of times we can at least improve the pain and function to a point where it's, more tolerable and the patient can get better quality of life out of that.
Great. Well, it's neat to see that this is where the vision is, right? I mean, long term. Yeah, it's pretty cool.
Absolutely. I mean, I think, I mentioned that there's in a lot of these fields, there's not necessarily great studies that have been done on humans, but a lot of the preclinical, so stuff that's been done in the animal models and things like that is super encouraging. So I think it's definitely headed that direction. It's just kind of a function of time.
Yeah, that's really cool. Yeah, I saw an article the other day where they're basically reversing aging in mice right now, which is like fascinating. It's like, how long is it going to take us to do that in humans? But it's very, very cool. It's the forefront of medicine right now, so it's great.
Yeah, speaking of that, Dr. Loch, how long would you say this field or this kind of study regarding what it currently is now has been around?
Well, I would say, again, my specialty is more towards the orthopedic and musculoskeletal part. So I know for, gosh, at least, and actually it goes back even further in horses and the equine community. They've been doing it for even longer than we've done for humans. But I would say at least probably 30 years. There's a physician in France, Philippe Hernigau, who was probably one of the first to start doing this sort of work. And he's been doing it for 30 years. So it's, in the musculoskeletal arena, it's been around for a while. And I think it'll only be a minute before these other areas will catch up. But so it's been around for several decades at least.
Okay. So we're on the cutting edge, but it is definitely nowhere near new or something that we're just now finding out about.
Correct.
And as far as, typically who would come to your clinic, we mentioned that you can't necessarily grow a new knee. So is someone coming in an acute stage, they just had an ACL tear, or are they coming in after, they had that ACL tear, it was repaired, now they have arthritis 10, 20 years down the line? Where do you typically find people in their journey, and where do you typically see the best outcome?
It can definitely be both. Although I would say just in my practice, it's definitely more of the chronic issue. Probably, I would say 70 to 80% chronic, where it's that long-standing kind of degenerative changes that you see over time. And then sometimes I will, 10 to 20% or somewhere around there, I'll see the acute injury, an acute tear of something, an acutely herniated disc, an acute, partial tendon tear or something like that. So there definitely are those, there are instances where both can be improved. It's my general feeling, and I think it just kind of makes sense biologically that the sooner you can get to something, you're probably going to do a little better with it. And we just see that just in general when people, for example, when people have arthritis, just like most things in medicine, right? If you can catch it kind of when it's in the mild phase or even the moderate phase, if we can intervene at that point, people generally do better than kind of when it gets to the severe point. And that's not true for all joints or all body areas, interestingly enough. For example, we, one of the things that we kind of pride ourselves on is you mentioned Regenexx is kind of a group of physicians, is that we like to, track how our patients are doing over time. And so we've got a pretty large data set, at this point, so we can kind of at least have some reasonable expectations and kind of know how people do over time. And some interesting things that we found out, for like example with the knee, is that we can intervene kind of at any stage of knee arthritis, even when it gets to KL4 or severe knee arthritis, that and the outcomes don't necessarily get any worse, so patients don't necessarily have a lesser chance of improving. So for knees that's true, but for something like the hip, Once you even get to moderate hip arthritis, interestingly, those patients just don't kind of respond typically as well. So it kind of depends on the body part too, but in general, the earlier the intervention, I think the kind of more it makes sense.
Yeah, that's helpful, because one thing it's kind of making all the rage right now is you hear Joe Rogan or those kind of strength and conditioning specialists kind of talk about lifting and messing up their shoulder and then going in and getting some PRP or something done and having it immediately fixed. So there's kind of, for me at least, there was kind of that disconnect in, is this more chronic or acutely used, and who's it beneficial for at that point? But it definitely makes sense, like we typically see with medicine, the earlier you can get to it,
Right.
the earlier you can intervene, typically the better that works.
Is it used as a preventive also? Like you don't have any issues?
Not typically. I mean,
Okay.
no, I know some places and some people, I think, kind of maybe a little bit more on the fringe will do it as preventative, but I think in general, unless you have some signs of degeneration, or unless you have some signs of or some symptoms, basically, some symptoms of something, to me, it doesn't make a whole lot of sense to intervene just for the sake of intervening.
Yeah. Can you, I kind of have an idea of what PRP is and things like prolotherapy. What are the modalities that are typically used for that?
Sure.
And
Yeah.
can you just explain what they are?
Yeah, sure. So there's a variety, obviously. So prolotherapy is one of the oldest and one of the kind of one that's been around the longest, and one that a lot of people are probably more familiar with. But prolotherapy is basically just the injection of a mild irritating solution. So say, for example, somebody's got some tendonitis in their rotator cuff. So the idea is to inject a mildly irritating solution. Usually it's dextrose, which is basically just sugar water. So you can inject that into the tendon. It just creates a little bit of inflammation, but it signals to the body that, hey, something's going on here. We gotta try to heal this spot. So it kind of just revs up the body's response to healing. And so that's just prolotherapy. So that's been done for a long time, particularly for tendon issues is probably the most common use of that. Although it does have some application even for arthritis. There's a paper published not too long ago it was during the pandemic sometime, regarding prolotherapy for knee osteoarthritis, and those patients did really well. So it has some applications there too. So prolotherapy, that's kind of the most basic. Moving up a little bit would be PRP, or what's called platelet-rich plasma, and basically what we're doing there is that's a draw of blood. And pretty much getting rid of everything out of the blood that you kind of don't want, except for the platelets. You really want to hang on to the platelets. Sometimes you want to hang on to the white blood cells. That can make a difference depending on what you're trying to treat. But the main thing is the platelets. And so you can have what's called leukocyte-rich PRP or leukocyte-poor. But again, the main part of the blood that you're concerned about in that case is the platelets. And the reason for that is platelets have a bunch of growth factors in them. And growth factors, there's 7 of them typically that are in platelets, and they're responsible for things like protein synthesis and enhancing collagen, helping to grow new blood vessels. So those growth factors, obviously, you can imagine, would be helpful when you're trying to heal something. So, and the analogy that I often give is for patients is that, when you get cut or something like that, one of the first cells to show up is a platelet, and that's because it's helping to clot and stop the bleeding. It's helping to repair the lining of the blood vessel and that sort of thing. So, so basically what we're doing in that scenario is we're taking the blood, getting rid of everything we don't want, keeping the platelets, and then we concentrate those. So say if you've got, normal concentration of platelets would be, 150,000, per ml or something of that nature. So we can concentrate that till it's, 6, 7, 8, 9, up to 20 to 40 times normal. And so that it's got a huge amount of platelets, and then we can re-inject those into the area where there's trouble. And that, that can become really helpful, not only for PRP, but for stem cell, because, certain areas of the body, when they get injured, they don't have a great blood supply to heal themselves naturally. So certain areas like the meniscus and intervertebral discs in the back, they just don't have a great blood supply. So when they get injured, it's kind of hard for them to heal. So if we can take those growth factors and things like that are responsible for healing and concentrate them and then put them where the problem is, that's kind of, the reason why it makes sense and it can help. So So a little off track, but going back to platelet-rich plasma. So that's, again, just getting rid of everything else, keeping the platelets. And then, kind of the big one is that everybody kind of hears about is stem cell therapy.
Yeah.
And so just in case, just to kind of go back to the basics and what is a stem cell. So, a stem cell is basically just a cell in your body that is capable of turning into another cell. It's capable of proliferating or, multiplying, and, into other different cells. And so it's kind of like a blank slate. So it can create, it can turn into other things, but it can also create more of itself. And there's different types of, stem cells. So oftentimes too, for clarification's sake, it's worth mentioning that, in all the applications that are at least legitimate, that have been studied, we're talking about adult stem cells. Nobody's really talking about embryonic stem cells or anything like that. That is,
right.
Definitely ethically, there's a lot of ethical issues with that. It's not safe even to begin with. So we're really talking about adult stem cells. So, and in the adult cells, there's, different stem cell lineages. So there can be, what are called hematopoietic stem cells, which are responsible for making most of the blood vessels, or I'm sorry, the components of the blood. There are mesenchymal stem cells, which are responsible for a lot of the cartilage cells, muscle, bone, fat, or adipose. So, so there's different types of these cells. So basically what we're doing is, again, we're getting the cells from somewhere in the body where there's a large concentration of them. And typically for me, and one of the best reservoirs in the body is the bone marrow. That's where a lot of the blood vessels, or that's where a lot of the stem cells are. You can also get them from fat or from adipose tissue, but there are some issues with that, and we can get into that if that would be of interest. But so bone marrow, you can get a lot of stem cells out of there. Again, kind of discarding everything else that we don't really want in that case. And we can do the same thing. We can concentrate those stem cells to a higher number and then re-inject those into the area that we're basically trying to heal. So, and those stem cells can do multiple things. So we mentioned that the platelets have growth factors. So stem cells, one of the main functions actually that we've, is kind of, we're learning more about all the time is that one of the other names for them is medicinal signaling cells. And it's because they coordinate a healing response. And so you can kind of, a good analogy is to think of them like a general contractor. So, you inject them into a certain area of the shoulder, they help coordinate all the other cells to help heal that area. And obviously, like we said before, they can differentiate or change into, a cartilage cell or a bone cell or a muscle cell, depending on the environment in which they're in. So they serve multiple purposes. They're anti-inflammatory as well. So that's kind of how, where we get the stem cells, how they work, and kind of why we would use them, basically.
Right. And you're getting all these cells from the person that you're treating, right?
Correct. Yeah. So the FDA has some kind of regulations around the use of this type of stuff. And pretty much what they say is, if you take cells from the person on which you intend to treat, as long as you don't, as long as you would do what's called minimal manipulation, so you don't mess with the cells a whole lot, and you don't really add anything to them or try to, again, manipulate them in any way, and as long as they're being used for the same purpose. So, for example, if you're taking a cell that usually would turn into a cartilage cell or usually would turn into a tendon cell, as long as you're using it for that purpose and you're using it in that person which you intend to treat, then the FDA is pretty okay with it, and they don't have an issue with it. It's when you start taking cells out of the body and doing a lot of things to them, or trying to grow them, or doing stuff like that, or you're using cells from somebody else. The FDA says you have to have a very specific type of approval for that process. And that's a decade-long, multiple $1 million approval to get that, which, right now, nobody has, with the exception of, obviously you can do bone marrow transplants for like hematologic cancers. So, leukemia and that type of stuff. That's pretty much the only area right now where you can do that sort of thing. Anything for orthopedics or, sports medicine or any of that kind of stuff, you can't take those cells and just put them into somebody else. So the FDA is pretty specific. So in my practice, all I do is cells from the person.
Yeah.
Yeah.
Sounds like the most invasive part of at least the stem cell part is getting the bone marrow, right? Isn't that pretty invasive?
Yeah, and I can tell you firsthand that's what most people are afraid of. Actually, that's the process that most people are kind of worried about, and because you hear a lot of bad things. I can tell you that after having done a fair amount of these, it really comes down to the technique. I mean, if you use enough numbing medicine, if you take your time, it does not have to be uncomfortable. I mean, I've done it on everything from 20 to 30-year-olds to, I think the oldest person I've had has been upper 70s or lower 80s, and I've never had anybody that has not been able to do just fine. So a lot of it's in the technique and how you do it, and taking your time, using an adequate amount of numbing medicine and stuff like that. And the actual risk of that part, the procedure itself, is actually not that high, especially when you even compare it to something like liposuction. So if you were to get the stem cells from fat and use a liposuction, the bone marrow actually has a lesser complication rate than that. So
oh wow, okay,
yeah. So it's the part that people are worried the most about, but it all comes down to technique. If you have a reasonable technique and again, you use adequate amount of numbing medicine to take your time, it should really be no more than mild to maybe moderately uncomfortable, but that should be about it.
As far as like the efficacy of the age of the person and the age of their stem cells, right?
Yep.
So does that make a difference? So a 70-year-old, as far as a 40-year-old, as far as a 20-year-old?
Yeah. No, that's a really good question. And so if I go back to, it is true that in general, as people age, their amount of stem cells goes down. That's just kind of a normal, process of aging. However, interestingly, when we've looked at this in terms of particularly knees, when we look at our knee data, we've gone back. I think we have over 10,000 procedures in our database now, and we haven't seen a change in efficacy with age. So,
that's really cool to know.
Yeah,
that's
which
awesome.
would suggest that now again, that's knees, not necessarily true for hips. Hips are a different breed, but so it does depend on the body parts as you're treating, but in general, for knees, we actually have not seen a drop off with age, which is really interesting. Which suggests that yes, the overall stem cell count may be lower, but that doesn't necessarily affect the outcome. So that's interesting. So again, it definitely does depend on the body part that you're treating, but at least in many of the joints that we've looked at, it doesn't seem to affect outcomes.
Oh, that's really neat to hear. That's cool. I'm just thinking off the top of my head, would it be efficacious or improve somebody's chances if, at 30 years old, they actually took out some stem cells and preserved them for later use?
Yeah, great question. And so you can do this in a lot of foreign countries, and you can bank your cells for later use, which I think does make some sense in certain applications. Can't do it in the U.S., unfortunately. Yeah. So and the other thing too, you have to look at, this is just kind of a side note, but if anybody is if you're ever evaluating like a study that gets published and it's in the news or something like that, no, stem cells can do this and stem cells can do that. A lot of times when the studies are done, they actually do allow the studies to take them out and grow them and to preserve them for a longer period of time. But you can't, but if you're on the treating side in a day-to-day practice, you can't do that. So it's kind of interesting. You kind of have to pay attention to a little bit of those nuances, but in general, on a day-to-day basis, physicians doing this type of treatment, you can't keep it out or bank it in this country, at least not right at this point. The closest place that you can do that, I know, is Grand Cayman.
Okay, that's good to know.
Yeah, that you can actually bank your cells and save them for a later date. So just a little tidbit there.
Okay, maybe making reservations to the Grand Cayman.
There you go. If anybody wants to go to Grand Cayman, there's a reason to go.
That's cool. All right. Wow.
Now, are you typically injecting at the site of the problem, Dr. Loch? Okay.
Yeah, and I think that's really important.
Okay.
We know actually from studies that if you just inject intravenously, which some places will do, about 80 to 90% of those cells get filtered out in the lungs. They just can't make it past the pulmonary vasculature, which gets really, really small, obviously, because you have to do gas transfer, between oxygen and carbon dioxide. So those cells really get held up in the lungs, and they don't necessarily get to where they want to go. So any procedure that we do, any procedure that I do, we're very specific about where we put it. And so I use image guidance for everything. So whether that's an X-ray or an MRI, an X-ray or an ultrasound, which we can see in real time. That's important to get to the spot where you want to treat.
Okay. And then as far as we were kind of talking about earlier, just the invasiveness of it, what should someone expect as far as it seems like, first of all, that you're kind of one-stop shop, like they don't have to go anywhere else to get the stem cells actually pulled from their bone marrow or
Right.
anything like that.
Yep.
What
Yep.
should they expect as far, do you do this treatment all in one day, or what's kind of their process that day, or kind of their rehab process and getting back to whatever it is that they want to do?
Sure. So the PRP procedure is done all in one day. So we do blood draw in the morning, process that in the lab, and then re-inject later in the day. Stem cell is the same way. Pull out the bone marrow in the morning. Takes longer, but we then re-inject the same day. And so it's totally normal and expected for people to be sore for anywhere from 2 to 3 days afterwards is kind of typical. And that's kind of expected because we're kind of again, we're generating a little bit of a response from the body. So it's going to be a little bit sore, a little bit stiff for probably 2 to 3 days. It's generally pretty mild. Most of the time it's not anything too significant. And then I always, most of the time it's activity as tolerated after that. If we're treating, especially if it's like an osteoarthritis type of issue, usually I have people lay low for a few days, kind of take it easy. And then we gradually start kind of a return to whatever kind of activity they want to do, basically. But for the most part, it's activity is tolerated. That changes a little bit if we're treating like complete tears or something like that. Those need a little bit more, a little bit more care up front. And then usually, at some point afterwards, kind of after that acute soreness or stiffness is kind of improved, then we start talking about getting back into rehab and therapy and that sort of thing.
Awesome. Okay.
Yeah. That's fascinating stuff. I mean, I just think about it runs the gamut from like replacing body part, from anti-aging like type supplementation to replacing body parts. Just makes me think like where we're going to be in another 30 to 100 years with this type of stuff. I imagine that patients don't get any insurance coverage for this, or is it all out of pocket expense?
Yeah, that's a great question. And right now, just because of the speed at which the medical establishment moves, it's it's the vast majority of it is out of pocket. We are every once in a while we'll sporadically see some carrier start to pick up like a PRP or something like that, but that's really far and few between. What we're doing at Regenexx is because we've got a large enough network now, and because we've got enough locations and physicians throughout the U.S., is that we're getting with smaller employers and showing them the data and saying, hey, look, for your employees, we can potentially save you this amount of money, and this is how people typically do, and they can get back to work sooner, et cetera, et cetera. So we've partnered with a lot of self-funded employers now. And I think have over 1 million covered lives throughout the country. This is all over the country, but for those people, it is a covered part of their benefits of their insurance coverage. So I think that's going to be how this ultimately plays out, is that the smaller self-funded employers are going to take that jump first and see how they go and run that little experiment. And then once the larger companies, larger insurers sees how that goes, then they'll be more likely to jump on and start covering too. So this is kind of, we're in the initial stages of that. And so we're getting these smaller companies, which are jumping on, which is great. And now that's actually a fair amount of what I see is probably 50% of the patients that I see are actually these companies that have this covered. And so,
and ultimately the reason why they want to jump on is because you're preventing people from going under the knife, right? And doing surgery, ultimately, right?
Yeah. I mean, if you're preventing people from, downtime and being out of work, and they're able to get back to work sooner, and, these companies ultimately have to, spend less on healthcare. I mean, that's, then it can be a win-win where, people get back to work sooner and the company's spending less. And so, that's why they're jumping on. And, once the big companies see, how it's going, I think they'll jump on too. And that'll be kind of the next phase.
Yeah, it's great. Yeah, it seems like the sky is the limit for this. It gets a bad rap though. It seems to. I mean, a lot of misinformation out there on the internet, you know.
Yes.
And the FDA seems to always have its say that, you know, it's not scientifically studied, or we don't have enough information. I guess like you, if you're in the trenches, what would your response be to that we just
Yeah.
don't?
I mean, I 100% agree that there is a ton of misinformation out there. There's
Yeah.
a ton of, sketchy treatments. There's a ton of stuff that really doesn't have unfortunately, any basis in either
Right.
science or reality. And so there is that out there. I think anytime you have a new treatment, there's going to be that, you're going to have those, people who jump in for that reason. But I think, this is one of those times when, yeah, I mean, you can kind of, on one hand, yeah, it's like the FDA and regulatory bodies take a long time, but on the other hand, they actually this coming month, they're starting, and they have been gradually, but they're starting to crack down on some of those places that are just doing stuff that's just kind of way out of bounds. And so I think right now that's kind of needed. We need that
Right.
that regulation, because at the end of the day, we want to keep people safe, and so we don't want a bunch of crazy stuff going on out there, because it's not good for the field, it's not good for patients. And so the FDA is strongly looking at that, and they're starting to embark on going after these places that are just, again, doing things way out of bounds, and that
Right.
things that don't have any basis in reality or in science. So
Well, well, speaking of safety, though, it sounds like if somebody is well trained in it, or knows what they're doing and is following the guidelines, it's very safe, right? I mean, it's much safer than surgery, it would seem.
yeah, and that's what we see, is that like you said, the caveat, as long as somebody's trained and they kind of know what they're doing. But the largest paper that we have on this is from 2015, and it looked at over 3,000 procedures, followed people for 9 years, and there's multiple different centers. I think it was like 18 different centers, and they found that, and this is again just for orthopedics, kind of the way that I do things with bone marrow and that stuff. They found that the complication rate was no more than just a regular, knee injection or a regular shoulder injection or something like that. So the most common complication was just discomfort related to the injection. I mean,
Yeah.
that was kind of it. So, so the complication rate was very low, and it was no more than, when people may have a steroid injection or anything like that. So yeah, if it's done, correctly, in the right circumstances for the right reasons, the safety is, I mean, it's very safe, because you got to think too, you don't really have a risk of having a reaction to the medication or an allergy to the
Right.
medication, because it's from you.
Yeah.
So,
Right.
so you're not going to have that problem. Again, obviously, one of the reasons the FDA is looking into is if you do start using tissues from other people, that can pose an immune system response, and you
Oh,
can
yeah.
have issues with that. You can have infectious problems with that. So, but again, you're doing it autologous or from the patient's own system, that's got a good safety record.
That's great.
And so what do you recommend as far as someone trying to navigate this right now and trying to find a good practitioner? What tips would you give them?
Yeah, no, I think that could be the most important question. And I think you got to look for a couple things when you're evaluating this type of treatment. I think one we've kind of already touched on is who's doing it, right? Because it should be a doctor that's doing it. What's their training? Have they been trained to do image guided injections? Because sometimes you see these seminars out there, and people have these seminars, and maybe a doctor gives the pitch, and it ends up being that somebody who knows who comes to actually do the injection, and it's a mess. So,
Right.
Who's actually doing the procedure? Have they been trained to do it? Because, a lot of specialties actually don't get trained to do image guided injections. So, so that's number one, is who's doing it. The next question is, where are the cells coming from, or where's the, whatever's being injected, where's it coming from? Is it coming from the person? Is it, supposedly coming from somewhere else? So you got to be very mindful of that. And then, are they using image guidance? I think is an important one. So are they using ultrasound? Are they using X-ray to make sure it goes where it's got to go? Because, if you just inject it into a random spot, it's not necessarily going to do as much good as it could. And do they keep track of how their people do? So kind of what's their success rate, right? is that, you get these claims of, we'll get however much percentage relief, but it's either way out of context, or you just don't have, are people keeping track of how their patients are doing? Because that's the really only way you can say, any type of success rate or any type of efficacy, is by keeping track of your own people. Yeah, exactly. So, and I think anybody who's kind of serious about the field, kind of should be doing that, because, if you want the field to advance, that's what we got to do. We just need more data. We need more studies. We need more people to kind of ultimately know, what's working the best. Because, in the time that I've been doing it, we have seen, I've seen changes in how we've done things, and not because what we were doing was not right, but because maybe we found a better way to do it, or, there was something like that. But unless you're keeping track of those things, you don't know. So I think that's a real important question too. So, those are the kind of, the big things that I would pay attention to that I think are real important.
Are there specific bodies like Regenexx that you're a part of that people can kind of keep an eye out for? And if they see that name, they know it's accredited or has some credibility to it?
Yeah. So, I mean, I'm a little biased, obviously, because I'm part of Regenexx, but there are some other bodies out there that do things pretty well. And I think, if you go to a Regenexx doctor, we've all been trained to do things the same way. We all do the same protocols. We all process process the cells and the PRP and everything the same way. So there's some standardization there, and what you're getting. But I think that doesn't necessarily mean that somebody else isn't doing it just as well, So I think if you ask those questions that we talked about, and you kind of, drill down on that, I think that's the most important thing for people to know.
Yeah.
And Regenexx docs are all over the place, right?
Yeah, they're all over the country, multiple different countries. So yeah, they're international. So yeah, there's a lot.
Cool. Very cool. Okay.
Can you tell us a little bit about your practice, Dr. Loch?
Yeah, sure. So, I do a combination of, interventional pain and regenerative medicine. So I kind of do a combination practice. So oftentimes people come in to see me, and, we're kind of talking maybe about both, or maybe they've, already had, other types of injections, visco supplementation or gel injections for the knees or things like that. And they're kind of, there for another opinion. So, I personally will pretty much treat any joint, including the spine, and I kind of take a comprehensive approach, and focus on a lot of lifestyle things too, and big fan of movement and keeping people exercising and doing that sort of thing. So I kind of take a comprehensive approach to it, and but yeah, I cover a wide range of treatment modalities. So
yeah, and now you mentioned movement. Obviously, it's very near and dear to my heart. Specifically, when someone's after they've had the treatment, do you recommend some sort of therapy or some sort of rehab protocol that they do to help? If we think about like someone has a total shoulder repair and they arthroplasty that and put it back together, when we're starting to rehab and start to develop the range of motion properly as we should, and kind of help with the movements, the passive movements or the active movements that we may be doing, we're kind of telling the body where to lay some of this tissue and how to develop. It seems like there's a lot more kind of cellular signals that are happening with this that maybe that's not as necessary. What have you found kind of in regards to that through your practice?
I still think it's always a good practice to kind of have people involved with, some sort of movement and some sort of therapy, especially depending on the severity that we're treating. But, oftentimes if people come to me, and especially if we're contemplating like a stem cell procedure or something like that, and they haven't done some form of physical therapy, I mean, number one, I want them to do that first. And then oftentimes, pretty much everybody who has a procedure, especially if it's a stem cell procedure, because that generally means they've got a little bit more severe of a problem. Usually around the kind of 2 to 3 week mark is when we kind of start initiating some form of therapy. And, a lot of people have opted for, home types of things just because of, everything, with COVID over the last year. But prior to that, especially initiation of physical therapy at week 2 to 3 is oftentimes what I'll do most of the time.
Okay. And are there any studies that you know of that kind of look at people who have that kind of passive movement added to the protocol versus, someone who's just sent home and kind of slowly grades back activity?
That's a good question. There's nothing, there very well may be. There's nothing that I'm aware of specifically looking at that. In other words, if they had a procedure and then those who did formal physical therapy versus not. I don't know that that study's been done. It'd be interesting to see, but not to my knowledge. I haven't seen.
And then can the average person use Regenexx to check out these studies, or do they go to PubMed, or where's their best option for kind of finding quality information?
Yeah, so Regenexx publishes a lot of literature within our group of physicians, and that can certainly be found at the website. It's just regenexx.com. But yeah, PubMed obviously is always a good resource, and there's also some journals now that are starting to be available. That are kind of just starting out that are covering this sort of thing. But if anybody, all bias aside, if anybody's interested in just learning more, the Regenexx website does have a great, group of studies and reports and things you can read to learn more.
Yeah.
I imagine on that site also it gives you the idea of like what to expect as far as length of treatment and when you need to come back and all that.
In terms of what to expect. And you can patients can pull up the database of outcomes. So if you're interested in your shoulder, you can go in there and see, okay, we've got this many shoulder procedures in the database. This is what the average pain level of people was coming in. This is how it changed over time. And so people can look at all that on the website too.
Right. Okay. Once you get, let's say you're doing a stem cell treatment, do you harvest stem cells once, or do you do it every time? I mean, do you?
Yeah, so you can do it multiple times. I mean, you can harvest cells multiple times.
And typically you need multiple times, right, for treatment, or
not necessarily. No.
So one injection, or one treatment that they can do it.
It can be one treatment, and that may be it. So
that's cool.
When people look on the database, those are for single treatments. So and most of the data at this point goes out to about 4 or 5 years. So when people are seeing that, it's a single treatment. Now you can repeat treatments over time if you need to. So if somebody has a stem cell treatment and they do great for 3 years, and then something happens and they kind of go back, you can redo it. There's no downside necessarily to redoing it. But most of the time we try to do one and hopefully have that be it.
That's really cool. So one and done with stem cell typically. What about prolotherapy then? Same thing?
No, so prolotherapy and so I would kind of say, prolotherapy is oftentimes a multiple step procedure. Yeah, so that's kind of where you're doing multiple procedures. And sometimes PRP can need a couple. So typically prolotherapy needs the most, PRP a little less, and then kind of stem cells. Usually we hope that's kind of a one and done situation.
Very cool. Okay.
And as far as making that choice for the patient, or helping guide the patient making that choice, how do you pick which modality of those you're going to use? Stem cells, PRP, prolotherapy?
So a lot of it kind of depends on what they've tried before. And kind of, in general, I'm kind of a fan of, we start with the kind of the easy stuff first, and we kind of work our way depending on what people have done. But it depends on what they've tried before. And then a lot of it depends on the severity. So if, people have a near complete tear of, rotator cuff or whatever it may be, that's just going to respond better to a stem cell procedure. So I kind of, in a way, don't want, they might not want to, I don't want to say waste their time, but they just don't have the chance of efficacy with something like PRP that they probably do with stem cell. So that's kind of where we move a little bit more towards.
Well, that's good for practitioners like me to know, because I wasn't aware of that. So it's like the more severe, the more.
Generally I tell
towards stem cells.
Generally I tell people that kind of, if we get it in the mild to moderate stage, they can do pretty well with PRP. If we're getting to that severe stage, that's probably going to be better for stem cells.
Yeah. Okay. Wow.
Other than that, Dr. Loch, I did want to ask, how did you get into this? How did, as you're specializing throughout your education, how did you fall into regenerative medicine?
Yeah, so it's kind of, I started in, as you mentioned, in anesthesiology. I liked being in the operating room. I liked, I just liked the procedural aspect of it. And, I was kind of always fascinated by the operating room. And then as part of anesthesiology, during training and residency, we go through and we do, some of the interventional pain stuff. So some of the injections, and that's where you kind of learn to do a lot of the injections. And so that part really was a lot of fun to me. I really enjoyed doing those procedures. And having people that were in discomfort and trying to get them back to, a better functioning level was really cool. And to me, anesthesiology, most of your patients are asleep. So there's not a lot of interaction, but with this, I was able to, interact with people and kind of help them get, I love to be active myself. So it's kind of, it's fun to try to get people more active and, live a little better. And so then regenerative medicine was kind of a natural extension of that. Just as kind of, that everything has progressed in the field. I just thought that was really, like we mentioned at the beginning, I think that's where the trajectory is headed. And so, I wanted to be in on kind of the ground floor and really get a good knowledge and be able to do it and be able to do it well. And so, so that's kind of where it all came from.
Yeah, that's awesome. Keoni, any other questions?
No, thanks for being on. It's fascinating. I clarified a lot of stuff for me, and certainly made me feel much more confident about referring people for this type of medicine. I've had a number of patients over the years who've had, especially with knees, where it was like one visit and they felt that they were back on their feet, so to speak. So that's really cool. It's unfortunate though that it's out of pocket, but at least here with some of my patients, it wasn't that big of an expense.
Yeah, it kind of depends on how involved it's got to be.
Okay.
It doesn't necessarily have to be. Yeah, I mean, I try to always meet people where they are. And, if we can't do a stem cell procedure right now because of some reason, well, maybe we start with PRP and we get you at least some relief for, for 6 months or 12 months or something like that. Maybe then we think about doing something different down the road. So,
yeah,
I think it comes down to having multiple options for people, multiple tools in the toolbox and, just being able to meet people where they are.
Great.
Yeah.
Dr. Loch, was there anything we didn't mention that you'd like us to bring up before we get done here?
No, I think that covered a good range of it. I think one of the most important things is for people to, just know how to evaluate and if they're interested in this type of therapy, just knowing the right questions to ask and knowing kind of how to look for somebody that knows what they're doing, has been trained well. And just, things are going to change a lot over time. This field is going to change super rapidly. And, like I said, 6,000, 7,000 trials going on, related to this kind of stuff. So things are going to change. But learning how to find somebody that can kind of navigate the field, I think that's super important. And we got to that. So I think that's the most important part.
Yeah, I agree.
Yeah, absolutely. Well, thank you for your time, and people can check you out at, what is it again? Coastal Spine?
Yeah. So practice website is coastalspineandpaincenter.com. And then Regenexx is a great resource for people. And that kind of, you can get to me through that link too. Sometimes I'm on Instagram, so Dr._Loch. And so sometimes I've got some regenerative medicine stuff going on there too. So all those things are good to check out.
I think I was checking out your page and you mentioned the multifidus muscle, so I was very happy. I knew we'd be friends then.
Yeah, right. Yeah, nobody ever mentions that, so that's great.
Yeah, near and dear to your heart. I tell you, it's a very it's an underestimated thing that when I look at a lumbar spine MRI, I always look at the multifidus.
That's awesome. I'm gonna sleep well tonight. Thank you, Dr. Loch.
Thanks so much for being on. It was great.
Yeah, thanks guys. I appreciate the invite. It was a lot of fun.
All right, take care.